Hello, my name is Rajiv Gupta and I will be talking about principles of dose optimization in head CT. So, for the remainder of this talk, what I will be giving you are some pearls and some strategies as to how we can control dose and minimize head CT dose. So, one of the first things that we can do is to make sure that each scan is justified and is properly ordered. Okay. Because even a low dose CT is too much dose when a scan is inappropriately performed. Most of the times this responsibility falls on our fellows or the people who are protocoling the scans, and they are the ones who are required to check with the physician what the indication is head CT required for this particular indication or not. There have been papers that have been published in the literature, for example, Brenner's paper in New England Journal of Medicine in 2008 that showed that about 1/3 of CT scans are inappropriately performed. So, it is one thing to just talk about the fact that it is a personal responsibility of the radiologists and of the fellows to make sure that the doses, the CT scans are properly ordered, but there is a systemic change that one can also make. Okay. So, back in about 2008-2009 time frame, MGH instituted a radiology order entry system. One of the screens is shown over here. This is actually not for head CT, but for chest CT, and it shows that every time a physician goes to order a scan, he will check on the signs and symptoms. He will know if there is any known diagnoses, and based on that, the system will actually give you what is the level of evidence that this particular scan is appropriate for this clinical indication. Okay. So, for example, in this particular case, the level of evidence is 9, that it is indicated for this particular case. There are times when it is in between or maybe, and there are times when the boxes are red and shows that there is very low evidence that this particular scan is required. So, for minor trauma, for example, there is really very little evidence that a head CT helps, okay, and the system will tell you that there is low level of evidence for minor trauma. Similarly, for routine headache, there is very little evidence and the system will tell you that. For major trauma or for headaches lasting over months, clearly this scan would be indicated and the system will tell you appropriately. Another thing that the system helps you with is to avoid unintentional repeat scans. So, every time you order a scan, the system will tell you that a CTA of the head was performed on this particular date, and so if you are ordering a repeat scan, you are better off looking and consulting that the previous scan exists. Okay. And you can click on how to interpret this result, and it will give you a detailed summary of what all these things mean. Okay. And it turns out that such help is very useful. It's a great help in reducing the overall volume. So, this graph shows you how the volume of CT scans at MGH has altered after the decision support system was implemented in the ROE. So, before 2009 time frame, you can see that there was a trajectory of growth, and that trajectory has been altered ever since the decision support system was implemented. So, we have found that decision support is a very effective strategy for controlling the overall CT volume, and is perhaps the best way to control CT dose at a population level. It would not affect at an individual level, but at a population level, this definitely has an effect. Okay. The second thing is about paying attention to the mechanics of scanning. Okay. This is not science. This is not very hard to do. Everybody kind of understands it, but it's something that needs to be emphasized. So, just to illustrate this point, I collected 9 scans from one single patient, okay, performed over about a 2-week period. The patient came in somewhere on the upper left hand corner, had a CT scan done. The CT scan was repeated. Then patient had a craniotomy. You can see the resection cavity. There was some hemorrhage. Patient was unresponsive for several days, and they continued to repeat the scans, and there was more hemorrhage, and finally the patient was discharged, and you can see stabilization of the overall changes within the CT scan. And now, if I were to ask you which scan has the highest dose and which scan has the lowest dose, you would have a hard time figuring that out. Okay. In fact, what is most offensive about some of the scans, for example, the scan in the bottom left hand corner, is the artifacts coming from the wires. Okay. So, you are not that sensitive to the dose as you are sensitive to all these other effects. Okay. The head is not centered, the head is not angulated properly. Okay. All these other changes count to some extent much more and create much more offensive artifacts within the image as compared to the standard deviation within the pixel, the quantum mortal within the pixel, which is what the dose actually controls. Okay. So, I would make a claim that so these are some of the dose levels. Here there are 3 different vendors, there are 3 or 4 different types of scanners, and the dose is varying almost by 100%. It is going from about 40 milligray to almost 80 milligray. Okay. So, there is a 100% variation in dose, but that is not what the eye is seeing. What the eye is perceiving is the fact that there are all these artifacts arising from metallic wires, improper positioning of the head, and so on. Okay. So, the point I would make is that the technologist is the #1 determinant of image quality, okay, because he or she is the one who picks the right protocol. He or she is the one who positions the patient properly, making sure that the head is in the head holder, making sure that there are no extraneous wires or hardware within the field of view. Okay. And I think that is something that needs to be emphasized to the technologists as often as possible. Okay. Another thing that technologists can do is to angulate the gantry or to angulate the head so that we are scanning along the skull base. And we are avoiding orbits whenever possible. So, it is showing you 2 positions in the scout, and it is not that difficult to actually change the angulation of the head or tilt the gantry, so that the patient is properly positioned within the bore. Okay. Another thing which is not emphasized, and maybe some of the technologists are not aware of, is the effect of centering the patient within the bore of the gantry. So, there is a study that was published in SPIE by Tom Toth and his group, which shows in a phantom study how much does the dose vary when you are off centering the patient. So, they started with a water phantom and it was centered, and you have a certain dose. Now, they elevated the phantom by 4 centimeters and the noise increased by 22%. Okay. Then they elevated the phantom further and the noise increased by another 30%. So, and this is coming because of the fact that the automatic exposure control and your bow tie filter is tuned to the isocenter of the gantry. So, if the patient is off center, there is a corresponding dose penalty to that. So, it is very important to center the head within the bore of the gantry. Good patient centering means good automatic exposure control and better image quality. Technologists should make sure that the scout is delimited to the area that is in question, and also the scout can be done at a very really low dose. Okay, typically 80 kilovolt peak and 20 to 40 milliamp second is sufficient. Okay. So, good scanning protocol would include attention to scan series, make sure the minimum required scan series are acquired and then are pushed to the PACS, that the scan length is targeted and focused, that the beam collimation is proper. Lower beam collimation is better because there is less scatter noise, even though it takes more rotations to acquire the scan. Gantry speed, faster speed is better because you can finish the scan faster, and that appropriate reconstruction kernels are selected. Okay. And these are some of the technologists' responsibility: patient positioning, making sure that they are instructing the patient to hold their breath while the scan is going on, making sure that the IV access is proper, delimiting the scan and picking an appropriate protocol, making sure that the transfer CT scans have the right scan range and scan parameters, and appropriate reconstructions and kernels are used. So, the next strategy that I would talk about is use of tube current modulation and optimizing the tube current itself. So, lowest possible tube current measured in milliamperes times second is proportional to the degree of intrinsic contrast that is there in the tissue. So, if you are looking at a tissue that has high intrinsic contrast, very low MA is actually possible. So, if you want to do a bone scan, you can get away with very, very low MA value, while if you are trying to look at gray white differentiations within the brain to figure out if there is a stroke or there is not a stroke, you need higher current. Okay. An acceptable level of image noise, again the same concept, that if you want to minimize the noise, the amount of quantum model that is there in the image, then you have to increase the MA value. But it turns out that the image noise is not directly proportional to the MAS. Okay. In fact, it is proportional to the square root of MAS. So, if I double the if I double the MAS, if I double the tube current, the amount of noise will drop by square root of 2, not by a factor of 2. Okay. So there is this disproportionality or non-linearity in the process that you should keep in mind. Okay. Another thing that one can do in order to minimize the tube current is to tailor the protocol to the clinical question. So, as I said, when you are looking at sinus CT, when you are primarily interested in bony anatomy, for example, functional endoscopic planning, or when you are looking at bony anatomy, for example, the sella, the pituitary issues before the transsphenoidal surgery, you can really drop the tube current. Something of the order of 30 milliamps second is sufficient. Okay. So, we did actually a simple experiment in 2004, and that has been published, where for all repeat scans we dropped the tube current almost by a factor of 50. Okay. So, on your left you have a scan that was performed at 170 MA, and then on your right you have a scan that is performed at 90 MA, and what you see is that there is actually not that much difference in the image noise. The image noise is definitely higher, but the important aspects such as gray white differentiation you can still perceive even in the low dose scan. So, the conclusion in this department wide study was that a 50% drop in the MA value did not result in with any significant decline in either in the conspicuity of the gray white differentiation or in the Hounsfield units. However, the overall contrast to noise ratio was elevated by 22%. Okay, this was published by Mark Mullins and Michael Lev back in 2004. So, there is a lot of potential here to reduce tube current, especially when the clinical question is not about gray white differentiation, especially when we are not looking at when we are not looking at a stroke case. The next thing that I would like to emphasize is the use of adaptive tube current modulation. Okay. Tube current modulation is available on all modern scanners, and what it does is it tries to modulate the current in proportion to how much attenuation there is along the beam, along the path of the X-ray beam, and it can vary the tube current both in the radial direction as well as in the axial direction. Okay. And substantial dose reductions have been reported using this technique. It is most used in head CT. It is most useful when both head and neck are scanned together, because the moment you go below the skull base through the neck into the shoulders, there is a very abrupt change in the amount of attenuation that the X-ray beam has to overcome. And even within the head, when you are doing only a head CT, it is important to have the tube current modulation on, because head is not a completely cylindrical object. Also, the thickness of the bone in the calvarium changes drastically. So, the frontal bones, for example, are much more dense than the squamosa of the temporal bone. Okay. So, in the AP direction, you have much higher attenuation than in the lateral direction, and the tube current modulation can actually account for that. So, there are some other considerations when we are titrating the tube parameters. So, just like MA on the tube is important, it is also important to lower the KV. In fact, the change of dose with respect to KV is nonlinear. When you double, when you increase the KV by about 20 or 15 to 20%, the amount of dose doubles. Okay, so it's a nonlinear change, and most of the and the KV also has an effect on the overall contrast that you see within the image. Okay, so realizing this, there are some newer scanners that are that now can advise you on what is the right value of KV to use. It's called auto KV, and we should use that whenever that is available. Also, whenever it's a contrast enhanced scan, for example in CTP, it is better to use a lower KV value because iodine is more conspicuous at a lower KV value. We are closer to the K edge of the iodine at 80 kVp than at 120 kVp. Okay. We should also avoid rescanning the same region again. For example, when we are doing a head CT, there is no real need to do a separate temporal bone CT if that's the clinical question. One can extract a temporal bone CT out of a routine head CT if it has been performed helically. Okay. And there are other quality parameters that can be optimized. For example, minimizing the motion, taking out all the hardware that is in the field of view, and optimizing the control bolus and the angle of the gantry. Okay. So, these are all the parameters that should be paid attention to while doing a head CT scan. Okay. Another thing that cannot be overemphasized is the fact that one has to have a whole suite of neuro protocols which are then tailored for the clinical question. So, when nothing is known about the patient, and you can do a routine head CT, but if it's a case of stroke, there should be a perfusion CT protocol that should use lowest current possible and should use 80 kVp rather than the routine 120 kVp. For temporal bone, again we can drop the MA value because we are looking in the bony anatomy. For sinus CT, we can really drop the value because again it's a very high contrast structure, and all these protocols should be available in order to minimize the dose and optimize them for the clinical question at hand. So, for example, here is a CT scan that was performed for craniosynostosis. It was done at 80 kVp, 60 MA, and overall exposure here is something of the order of 0.04 to 0.08 millisieverts. Okay. If you look at the CTDI volume here, which is given under the CTDI wall, it's only it's less than 2 milligray, which is actually very good given that the head CT scan, the ACR guideline on that is 75 to 80 milligray. The next strategy that one should employ is the use of iterative reconstruction when it is available. So, there are the newer algorithms that are available which try to minimize the overall image noise by iterating over an objective function and trying to minimize doing a reconstruction which is iterative rather than based on filtered back projection. Okay. So, here is a case which uses an iterative reconstruction algorithm called ASER, Adaptive Statistical Iterative Recon from GE, and on your left hand side is the algorithm, is the reconstruction with ASER, and on your right hand side you have the filtered back projection reconstruction, and what you see is that there is much less noise in the ASER reconstruction than there is in the filtered back projection, and the algorithm is able to decrease noise to the extent that even at the thin slices, at the thinnest slices available, 0.625 millimeters, where the filter back projection is not able to show you the gray white differentiation. We are beginning to see actual gray white differentiation once the Acer algorithm is employed. Okay. So, we have found this to be very effective. Here is a table, slightly older table, that shows that we can get up to 30% reduction in dose with the use of Acer. So, we can reduce the tube current by as much as 30% if we are able to use if we use Acer as opposed to not using the adaptive statistical iterative reconstruction. So, so the take home points here are that there are multiple strategies that one can employ in order to minimize the dose. First and foremost, justify each scan, make sure that each scan was warranted. There are times when we can change the modality. For pediatric cases, we can sometimes use an MRI scan instead of a CT scan. And even when we need to do a CT scan, we can do a CT scan at a very low dose, and if an abnormality is found, we can confirm that on an MRI. There are multiple ways of not doing a CT scan and doing a CT scan only when it is completely warranted. I also showed you some cases where paying attention to the mechanics of doing the scanning is very, very important. So, make sure that the patient is centered, because when the patient is not centered, there is a dose penalty associated with it. Make sure that the right protocol is employed, make sure that there are no extraneous wires within the field of view, make sure that the head is angled properly, make sure we are trying to avoid the orbits either by rotating the head or by tilting the gantry. Minimize the milliamps, the tube current as much as possible, and use tube current modulation, because tube current modulation will make your scan somewhat resistant to changes in the attenuation both in the radial as well as axial direction, okay, especially when you are doing head and neck scan together. Also, the thickness of the calvarium changes, and the use of modulation, tube current modulation will help you with that. Okay. We have found that 120 kVp is sufficient for routine head CT. However, we can really drop the kVp to almost 80 kVp for CT perfusion as well as for infants and for other indications such as craniosynostosis. Dose changes superlinearly as kV is increased. So, reducing the kV kilovoltage on the tube is important, and there are newer scanners that allow you to do that automatically, and we should use auto kV whenever it is available. It is very important to tailor the protocol to the clinical situation. So, if when you are scanning bone, when you are scanning anatomy that is intrinsically high contrast, you can drop the dose significantly. One should avoid the orbits by tilting the gantry or by tilting the head whenever possible. For pediatric scans, we can actually reduce the dose significantly. Typically 125 MA or even lower values are sufficient. We can do most scans at half the adult dose or lower. Okay. And overall, there is one should try to minimize the variability in the amount of CT scanning that is done at different scanners by making the protocols uniform and by education of all the users, the technologists, the radiologists, and the ordering physician. So, I think with that I will stop. These are some of the take home points that we have learned in our practice here at MGH.